Hello, everyone. I'm Dr. Kirti Chadha, the Chief Scientific Officer at Metropolis Healthcare Limited, and I welcome you all to this very scintillating scientific podcast on preventive oncology, cervical cancer. Let's get together and prevent the preventable. And who do we have as the guest speaker? None other than Dr. Priya Ganesh Kumar. She's a very well-known doctor, but I would like to introduce her to you so that you understand the preventive oncology that she's shaping up in this country. She's an entrepreneur and visionary and started the first ever chain of 27 preventive oncology franchisee centers pan-India. She's also a course convener for FOGSI, IARC, and the WHO. She is currently the chairperson for FOGSI for the Gynecologic Oncology Committee. She's a master trainer for state government of MP and Jammu and Kashmir for cervical cancer prevention. And believe it or not, but she has trained more than 1,500 gynecologists so far. And with that, I welcome Dr. Priya. Welcome, Dr. Priya.
Thank you, Dr. Kirti. It's indeed a pleasure to be with you in the podcast. Yes, and I know you all have also been doing a lot of work, so I'm delighted to be with you.
Thank you. So to start with, Dr. Priya, can you just throw some light on preventive oncology and what has been your role in establishing this concept in CA cervix domain?
So as Dr. Kirti, we all know that, cancer is a word which really, in fact, it actually makes us also scared, and our spine is erected and with all those fibers out. The main thing is what it gives us a shiver, the cancer word, is actually not so. The main thing is we can have a preventive part even before a patient gets into, cancer. So that's the main thing. And in this, we have developed ourselves, in fact, if I can say that with a three-pronged approach of patient awareness, that is public awareness, as well as capacity building of the doctors in this field. And third thing is encouraging the politicians and the public policy makers to take up this field more seriously. So in this way, we have seen through as a holistic approach that if we can get all these arenas working together, then definitely we can have the preventive part, more emphasis on the preventive part, because as we all know that cervical cancer is only one cancer which can which has a 15 years long period of precancerous conditions which can be tapped in that primitive stage of pre-cancer where the cells have yet not gone into the cancer.
That's right.
And yes, and that's how doing certain activities into it, we can develop this preventive oncology in a much more robust fashion.
That's right. And actually, we've been very lucky to have, nipped all these cancers in the bud. And as you said very correctly, once we are able to find it and, catch it in the precancerous stage. And I know so many women out there who have been, treated very well. So, Dr. Priya, as an expert in this field, how many cases of cervical cancer do you come across on a daily or a monthly or an annual basis?
Okay. So, Dr. Kirti, see, I'll tell you this now, cancers, you have asked me specifically cancers of cervical cancer. Nowadays, in the urban areas, we are not getting so much of a cervical cancer because urban ladies have become more cautious about their health, and we are getting more of preventive, there's a precancerous conditions. So probably in my OPD of, I might be doing around 100 colposcopies in a month, and I can identify around, say, 30% of them as precancerous conditions, because ours is also a referral center. But now in this, I might be 6 months, may once I might get a cervical cancer out of this, but they are all into the advanced stage. But now to share again, all my rest of the 26 centers, or probably even 20 centers who are in the tier 2 or tier 3 cities of India, here the cancer cervical rates are almost, we are seeing 1 to 2 cancers in a month, or so they are all coming from those Adivasis and the slum areas. So that itself shows that there is a lack of awareness about the preventive part, and cancers are coming to us only when they are coming into the late stages. They've developed late stages. So that's the main thing.
Yeah. So unfortunately, I still sign out a significant number of cervical cancers. And being an oncopathologist, I think something that gets me very depressed is when I sign out a full-blown cancer, high grade, high stage, which is totally preventable. And, in our setup, I think most of us, most of the histopathologists are at least signing out 1 to 2 cervical cancers daily. And that is the kind of burden that we are seeing, whether it is across rural and urban. And, it is very saddening. So I think let's move on to how do we go about it. So out of these cases, Dr. Priya, how many do you think women were screened and how many did not even get screened once in their lifetime?
So all the cases, as I told you, all the cases who all have come with the cervical cancers truly have not got their screening. None of the screening things have been done for them. They aren't even aware of it. They come to us only when we see in the post-coital bleeding, or they come to us with symptoms. And so these people haven't got any screened. But now to talk about the where I'm practicing in the urban area. So here basically people are slightly aware. They would have got their screening done once, might be in the whole of their reproductive age group, might be once, and might be now since they are being referred to us, so they would have got certain referral doctors would have done certain screening. That's once or twice in their lifetime. So that's the story.
Yes, it's very unfortunate. It's very unfortunate. One of the most common reasons for developing cervical cancer is just because we have not prevented it. Either somebody is not vaccinated, or even after vaccination, they have not really undergone the screening process. So, Dr. Priya, what would you recommend of these women who are screened, or the conventional screening that is going on in your centers and the other centers? What are the methods being employed from VIA, conventional cytology, liquid-based cytology, HPV?
We have categorically seen to it that we have developed protocols which we have say like 29 centers, like 27 are my referrals at the other centers, and 2 of my own main branches in Thane and at Delhi. What we follow, Dr. Kirti, is to do primary HPV screening. Along with that, we do a co-test, LBC. So this is what we have been adopting. But in cases where in the tier 2 or tier 3 cities, suppose because of the lack of resources and the lack of funding, probably the HPV might be cut off, and few of my centers are still with LBC. So this is one thing which we are doing, and there are 2 things which we see. We have an approach, like suppose if we are doing a community based camps, which all my centers do once in a quarter, we have been doing. So when they do there, that's a VIA screening, because there is absolutely no funding, is free of cost for all the ladies. But knowing that there is a lot of falsies, so whoever are VIA positives, then they come to the center and get themselves completely checked up. But the ladies who are walking into our centers, per se, into the clinics and into the preventive oncology centers, there it is mandate that every lady above the age of 25 goes for an LBC, and they come above the age of 30, they do have to have their HPV test done. So this is how we have adopted the protocol, and we have been following it since a decade now.
That's right. So we are also strong believers and, advocate the concept of co-testing and, as is recommended by all the guidelines today, whether it's the US Preventive Services or whether it's the ACOG guidelines. So all women between 30 to 65 years of age must get a co-test of HPV and LBC or any kind of cytology once every 5 years. And if they are skipping the HPV, then, we have to do cytology every 3 years. And yes, from before 30, they can just, get away with the cytology. And as you said very, very correctly, where nothing is possible, where nothing is available, there are no resources, then at least VIA should be done. But absolutely, wherever it's possible and feasible, high-risk HPV screening and cytology, preferably liquid-based, is really good. And you will be shocked at the kind of percentages that we saw. So data is published in international and national journals. And we saw a 9% positivity for HPV across, in our database. And out of that, about 3%, 2.5 to 3% people which are actually pathological, and, they need, treatment by our esteemed gynecologists. So that's a good thing. So Dr. Priya, what is the kind of positivity that you have seen by the various screening methods?
So let me tell you, last year, I just took the data for this 2021. I was looking into all my data. So this year itself, what we have found through all my centers, the HPV positivity rate is around 6.9 to 7%. I can put it up in that way, 7% of HPV. And that too, in that itself, 16 and 18 would be around 2 to 3%, and the rest are non 16, 18. So that's one thing. And with LBC, what I've found is the LBC positivity rate, if I can say, more than ASCUS. Now, SIN2 plus and SIN3 plus, I'll tell a little later, but more than ASCUS plus, I'm getting a rate of 10 to 11%. And in that SIN2 plus rate, I would be getting around, somewhere around 4.5 to 5%. And SIN3 plus, I'm getting around 2 to 3%. So this actually, for the benefit of the audience, SIN2 plus and SIN3 plus are the main precursors or the precancerous conditions, which are called as high-grade squamous intraepithelial lesions. And these are the cases where we have to pick it up and treat it, identify it, treat it, so that they do not go into a cancer stage. So that's the data, which, I haven't taken the whole data of the whole decade, but then, of course, I was very interested to know this year and the last year subsequent, they are also around in the same this thing itself.
Right. So there is a huge population which you and I can impact, and, we can quickly find these people, we can treat them, and we can, avoid a full-blown cervical cancer. So have you seen this trend changing much over the last 5 to 10 years?
Yeah, I have seen a slight change, the trend change. These are through the centers which I have been working, basically. Is that since we are now advocating too much, we are actually a voice now in the country, and wherever the centers are, they become real brand ambassadors. So what we have seen is we are getting ladies, ladies are walking in. I'm very happy with that. It's very enlightening to see that the ladies do understand this. The policymakers do understand it, or the local leaders do understand. So they are getting the ladies for screening. It is, albeit the fact it's very less. I'm not saying that's a huge thing, but yes, ladies have started understanding it. Hence, our precancerous conditions, detection have increased more. So we are able to identify the precancerous conditions where otherwise it would have been just silent. And these ladies would have shown later in the cancerous stage. But the detection of that has increased. Our colposcopy rates have increased. Ours is a state-of-art colposcopy center with a unified reporting system coded across the country. So the rates of colposcopy have increased, and the rates of precancerous treatment also has increased. So the leap and lets have gone high. CKC, cold knife conizations have gone high. The ablative methods, yes, they have also gone high. So what we are seeing is this trend has changed because of the voice and the noise which we are making, and the presence which we have across the country. I think, Dr. Kirti, you will also agree with me that even Metropolis, I'm sure, would have seen this changes now.
Yes, yes, Dr. Priya. And yes, really happy to know that, the clinical and the lab side are moving together in synergy, and it is really impacting patient care. So, Dr. Priya, now, for the benefit of our listeners, once they do get detected screen positive, what are the treatment options for them?
Yeah. So this after the screen positives, they do come for the colposcopy, and then we identify whether these lesions are, and that's more on histopathological understanding. Of whether they are SIN2 plus or SIN3 plus cases. And then they have to undergo proper treatment. So if they are on a very high, high grade, like the SWEDE 9 or 10 or a high SIL, SIN3 plus, we immediately get to go with expedite treatment with CKC or LETS, that is large loop excision of the transformation zone. And if they are in SIN2 plus category, where they can be, albeit the fact it can be SIN1 or SIN2 plus, the SIN2 plus and all shows into high-grade lesions. So their ablative treatments like cryocoagulations or thermal ablations have taken up the major role. They have to have the criteria to be filled up for ablative treatment. And surprisingly now, since we are doing a lot of camps in the rural and Adivasi villages, where the patients do not come back to the clinic, we have increased our strategy of screen and treat policy. And there itself, when we do by VIA and we find the lesions in the second, the neighboring, the adjacent room, we have a colposcope as well. And we immediately detect the lesion, try to detect the lesion and treat it. So there the treatment goes with ablative, and if it is not suiting the ablative criteria of cryo or thermal ablation, we do a let's there and then. That's an excisional treatment there and then. Only the cases which we suspect as a cancer, then we take them to the center and the onco center and then treat it. So in this way, the whole thing is moving around.
That's right. So, Dr. Priya, I think let's move on to the WHO's vision, right? So, there's a very, very strong narrative coming from WHO. And can you highlight, for the benefit of the listeners, the WHO's vision for cervical cancer elimination?
So, WHO, that's a World Health Organization, made a historic statement and a historic narrative, very rightly said by Dr. Kirti, that is 90-70-90 mission. So, what's that? And it has come up with a statement that cervical cancer elimination is possible. And the elimination goal, that is goal 2030, has been narrated very strongly, very loudly. And most of the countries have taken part in that. So let's understand how to do that. And they've come up with the 3 mantras. What are they? 90-70-90 is it's a magical figure which they have given. So 90% coverage of the girls below age of 15 with HPV vaccination. We all know the fact that cervical cancer is caused by human papilloma virus. So since it is infectious in cause, we do have vaccines available for it. That is HPV. We have bivalent and quadrivalent vaccine, and now we do have nonavalent vaccine. And to name the brand also, we have a Gardasil, which is a quadrivalent vaccine. Gardasil also has come up with a nonavalent vaccines. This and Cervarix is the bivalent vaccine. Now, this has to be given below the age from 9 to 14 years of age with 2 doses 6 months apart. This will cover up the high-risk strains of 16 and 18. If it can be given as a catch-up vaccination till the age of 26 years or even extended till 45 years as per the FOGSI guidelines as well. And in the older age group, that is beyond 15, we have to give it in 3 doses, that is a 0 month, 0, 2, and 6 months. So this is the 3 doses coverage, and that's the primary prevention. The 70% coverage of the ladies who are eligible for screening from the age group of 30 to 65 with a high impactful, screening methodologies. And the recommendation by WHO is HPV. And HPV, at least, what they are saying is every 5 years from 30 to 65 years. So that means you catch the virus itself rather than the morphology of the tissues later on, which has been seen on cytology or with VIA. So we take up the screening with high impactful screening methodology, that is HPV, which is a recommended one. But if you have to have a cafeteria approach, depending upon the resource setting of LMIC countries, then it becomes a VIA can also be taken up, and 7 methodologies are given as screen and treat or screen triage and treat by WHO. Or otherwise, even cytology can be taken up as a primary preventive screening methodologies. So 70% coverage of the ladies who sit from 30 to 65 years, and then 90 is detecting, the screen positives, treating the precancerous conditions or the cancerous conditions by various methods, radiology, radiation, surgeries, and chemo radiations as well. So this has to be the coverage of the general population so that we can get the cancer reduced by less than 4 per 100,000 women. If we can do this, we can adopt these magical figures, the magical mantras of 90, 70, 90. We can envisage that in the future, by 2030, if you are able to do this, of course, it appears a little bit more the same. So, okay, so less than 4 per 100,000 women of ladies would have cervical cancer. So that's what WHO is envisaging and has propagated.
Right. So, as the chairperson of FOGSI Gynaec Onco Committee, how have you managed to incorporate this vision in the Indian perspective across the country? And what steps are being taken by the Indian obstetrics and gynecologists?
Right. So FOGSI is Federation of Obstetric Gynec Society of India. This is the largest professional body. We have about 38,000 strong members, gynecologists, pan-India in this FOGSI. Now, Fox, as a committee chair, even before I joined as a committee chair, we had gone through an understanding of the awareness amongst the doctors, that's the healthcare providers, and awareness about this in the local population as well, in the general population. And it was very strange. And I mean, we had done a survey. In the survey for the general population, what we found was the awareness is really minimal, and leave apart, screening and all that thing. So I can just give you a few, this thing that we had asked about simple questions. Are you aware of the vaccines? And around 4,000 ladies had taken part in this survey, and 70 gynecologists had taken part. Pan India, this was a survey. And we tried to understand their basic understanding about this subject. And are you even aware of the vaccines? The answer was 30% only. Then we ran, and then about screening, it was again 30, 35% and all that. So when we understood that there is definitely a requirement for actually sensitizing this public, we'd have developed public awareness videos in 8 different languages through FOGSI, which is there in the FOGSI website as well. This is for the general public use, and as well as a counseling tool, AV tool by the healthcare providers. Then again, so this was from the health care public view. This was from the public end, and now from the gynecologist end. What I saw was many of the, and what we all have understood, one thing is gynecologists are more interested in laparoscopy, of course, high-risk obstetrics, and the areas where there is a definite need for the gynecologist to take part in. But also, it is the gynecologists who are seeing the patients for the first time, ladies for the first time, and then they have a lot of opportunity to screen these ladies. So understanding the fact, we had done a survey for the gynecologist also to understand their level of understanding for this preventive oncology part. And again, there it was, people knew about it, but when it comes to nitty-gritty, they were not very clear about the whole part of it. So then there was definitely a need to teach them, to train them, to create an awareness within them, and do to the capacity building in them. So for the capacity building part, I have developed Swasth Sundar Nari preventable, programs. Now, these programs have started from the month of August, and today is December. Yesterday, so we have 256 societies of FOGSI. 256 societies in tier 2, tier A, 1, 2, and 3 societies as well. So whenever we are doing, all the gynecologists are within this 256 societies of FOGSI. We have already covered in this last 4 months, we have covered with this program, we have covered around, I can tell you, 65 societies. And they are taking it up so well, and around 15,000 gynecologists have so far trained in this SSNPP webinars. Now, these webinars are talking about screening, because I understand not everyone are colposcopists and not everyone can jump into colposcopy. So, but everyone are preventive oncologists. Every gynecologist is a preventive oncologist. So this is very useful tool for screening. So making them understand the screening guidelines, making them understand VIA screening interpretations, HPV vaccinations, talking about Bethesda. So Bethesda revisited, sort of this, it's also incorporated into this SSNPP webinars, along with case-based discussions. It's really giving a very high impact, a high powerful thing, and people are now waiting to have in their societies too. So in this way, and FOGSI is committed. Let me tell you, Kirti, we are working in all the aspects, even public awareness, public domain, governments. We are having a parallel, tie-up with the governments. Then staff nurses, ASHA workers are also being trained in the program. And our FOGSI president, Dr. S. Shanta Kumari, she's a visionary. She has her things quite clear. She has made, a charter of how we should be going ahead. So in this way, and all the presidents who all have been till date, they all have been visionaries, seeing to it that the women health is given the priority in as a holistic way and an holistic approach. So that's the FOGSI doing for the.
It's really amazing work happening there, Dr. Priya, under your leadership and guidance. I think it's really good work, and best wishes to you and the FOGSI Gynec Onco Committee to notch it up and make a significant impact. So, for all the gynecologists and the other preventive oncology healthcare workers who are working along the same vision and mission, what advice would you give them that how should they counsel these patients, or actually we cannot even call them patients, just women, and how can we educate them better for achieving at least a 70% screening target? Would that be fair? 70% screening target to go start with? Yeah.
So now that our target always should be high so that we at least achieve the half of it.
Right. So how would you counsel them? So how would you counsel and educate,
Yeah. So the counseling, what I normally tell to all the gynecologists, even when they come for our training programs, counseling is the major part. And so the role play and all we do. So normally this is an advice what I would give from the experience. Of course, I'm not nobody to give an advice, but I can share that experience that if a lady comes to you, kindly ask her, rather than talking about cancer and putting them off, we shouldn't be actually scaring them out so that they do not even participate in your counseling part. So the main thing is tell them that do you really wish to have a pink health? So these are the words which you should be putting up to them. And if they say yes, of course, everyone wants to be in a pink health and everyone wants to be, having a good health and healthy thing. So ask them, have you got your BP blood pressure checked? Have you got your thyroid checked, or have you got your diabetes checked? So they would definitely, everyone would have done that at least. So then simultaneously slowly pull up the rope and say, then have you got your cervix checked? Have you gone to see that whether do you have any, the major symptoms or major signs like that? So once you start putting up these words, they will start becoming inquisitive. And that's the time when you have to show by the pictorial diagrams. We have built up pictorial diagrams where we have shown that before the cancer, you do have 15 years, and that's the good news to you. So talk sweetly about the good news rather than scaring them off. So tell them about the good news that there is a pre-cancerous stage for 15 years. And suppose and also give them the synonyms. We also give them those examples that suppose if your tooth has got caries, then the caries tooth is only operated or removed or whatever. The whole jaw is not removed. So similarly, saying that to avoid hysterectomy, because we never want our patients to just run to do an unnecessary hysterectomies. So this is one of the major part which we have been creating an impact on pan-India. So we do have to say that, for simple things like white discharge, even if there is no white discharge, it is imperative on all the ladies above the age of 50 to get their screening done. This is very, very important. Every 5 years by HPV, if there is a money constraint, then at least 3 years, a pap test, more preferably in liquid-based cytology, is one of the major things to be done. And if that is there, do not get scared. Even if your HPV is positive, there's no need to get scared, because HPV being, it can become, nil by age of 1 year. So definitely it's not progressive. Only the progressive HPV, so it regresses, but only the progressive HPV, if there is a persistent HPV, that's what we call as progressive. The word is not right, progressive. It is the persistent HPV, if ever there is. Then we do have signs to understand, has it caused any reactions or the cellular changes or the tissue changes by colposcopy, histopathology. And the good news is, even if it is, then there's no need to worry and get your uterus out. Rather, get the treated of that portion which is affected, that is cervix, and that's it. So saying all these things and showing them the videos which we have generated through our committee activity in the FOGSI, I think there is definitely a ray of hope, Kirti, I feel, Dr. Kirti.
That's lovely. That's lovely to hear, Dr. Priya. So as we come to the end of the session, I would like to just ask you one last closing comment. What is your vision for the next decade, and what do you really forecast how things are going to go from here, and practically what is going to be achievable and possible? What is your vision?
Okay, so now if you ask my thing, what I forecast in this coming decade is, of course, that is 90, 70, 90 and all is not, it's, at least for our country. I don't say that it is not achieved because I don't like to go in a negative term, but at least what we can do is, even if we achieve for vaccination, even that 90% also is not required. Even if you achieve 50% of what we are doing today, we improve ourselves 50% above in vaccination, in screening, 50 to 60%. Now 70% is what they are thinking of. It is achievable. Believe me, dear friends, it is achievable. And we then can, think about, I'm not telling you directly to go into 90, 70, 90. If you're doing it, super. But if you aren't able to achieve at least 50% of what is achievable, if you are able to do, and I think, Dr. Kirti, this is achievable.
Yes, I believe so too. So thank you so much, Dr. Priya, for your wonderful presence and experience and thoughts. I think everybody will benefit from it. So, all the people over there, prevention is the best treatment, so let's get on to this bandwagon. Vaccination is compulsory. You have to get the HPV vaccination, and whether you've got the vaccination or not, you still have to go ahead and undergo your cervical cancer screening till the age of 65, and if it's all clear, then you can go off it. But if you've never been screened till 65, then you better do it even after that. So many times we see 70, 75, 80-year-old women, landing up with a CS cervix, and they've never been screened. So it's preventable. Let's go on and prevent it. Thank you so much for attending, everyone, for listening. Stay safe. Bye-bye.
Thank you, Dr. Kirti.
Thank you.
And Happy New Year to all of you all.
Thank you, and same to you. Bye-bye.
Yeah.